to participate in the first annual Bold ERG Women History Month events. We are going to be focusing on Black Women's Health Matters. And I really want to special thank you to our Bold Executive Board members, Dr. Daryl McBride, Mr. Arthur Breeze, Mrs. Dawn Fisher, Mr. Brian Lieberman, Mrs. Michelle Antle, and also a special thanks to Miss Heather Davis, Mrs. Liz Zigmont, and Miss Joanna Kula. I don't know how to say her last name. I'm not going to butcher it. And I should have asked her before. But I really want to thank them for the work that they have done to market. The marketing looks beautiful and keeping us relevant on social media with the different things that we are doing. So I'm so happy that they have been able to support us. And as we go through this month, we have a lot to offer. Very excited. My name is Dr. Vicki T. Sapp. I am the Director of Student Engagement, Diversity, and Inclusion. And I also serve as an assistant professor in medical education. And I am the BOLD co-chair. And so working with the education subcommittee, they have done a lot of work and really want to thank them as well. We have a number of events lined up for this month, and there's the flyer. We've put it out so that everyone could pre-register. So thank you so much for pre-registering. Very important to be able to do that. Now, I like to give a little overview about BOLD. I'm not going to read everything, but really wanting you all to understand that in BOLD, what we try to do, and it's the Black Outreach Leadership Development Employee Resource Group. And what we try to do is connect individuals from African descent. So we offer support, wraparound services, as well as do programmatic initiatives similar to what we're doing today. It's also important for you all to know that this event is being recorded. And if you do not want to be recorded, by attending, you agree to be recorded. If you don't want to be recorded, then thank you so much for joining us. Okay. Also, very excited to inform you that we have mugs this time. Last month, we gave out masks for individuals who participated in the event. This month, we're going to give out these cultural relevant mugs. And I'm going to drop the link in the um, chat box. Enter raffle to win mug. And if you're interested in winning a mug, you have to be in it to win it, and you have to sign in to the raffle if you're interested in being winning a mug. And what I will do is randomly select you through this random website that Michael Yee, one of our students, he found this random selection website that we could use and to enter the winner. So you have to sign up on the spreadsheet. I believe that it works. I tested it. It works. If it doesn't, let me know and I'll figure it out. And so this is another, so there's 4 different type of mugs. And what happens is when you win a mug, and I'm only giving away 5 and you can only win 1. We had multiple people win masks, and that was exciting because we had a lot. There's only a limited amount of mugs, and we are only raffling off 5 per event. And I think we have about 12 events. So we have a pretty good selection of mugs too. And so you'll only be able to win 1 though. So if you win 1, stop entering when you go to the events. But we still want you to come to the events. So the first thing I want to do is play this video because this is the opening ceremonies for uh, Black History, Women History Month. So I want to play this video for us to set the tone. Very excited about this, and I hope I'm going to do this right. I don't know if I did it right. Let me try again. Oh, okay, I grabbed the wrong thing. I think I did it right. Let's play this video just to set the tone. It's so powerful.
But while I may be the first woman in this office, I will not be the
Something
last.
about my sister, girl. Something about my sister, girl. Said I love my sister, girl.
You are destined for greatness.
Said I love my sister, girl. Juicy lips, curves and hips. A natural queen, she possesses all the right things. She'll make a meal out of beans and rice. Take something from nothing, she knows how to sacrifice.
You're special and worthy of praise. Don't shy away
Her
from
clothes
it.
are sometimes clearance, but you can't tell, 'cause she coordinates so perfect, and she wears them well.
We can do anything.
Decent shoes are on her baby's feet. She'll stretch $1 for the rest of the week. I love my sister. I love my sister. I love my sister.
Not even me
about that girl
can stop me.
I love my sister, girl. Said I love my sister. I love my sister. I love my sister.
So I want all the girls watching here now to know that a new day is on the horizon.
Dark and lovely, peanut butter too, caramel tone, mocha chocolate and beautiful red bone. Short or tall, long hair or rocket ball, it doesn't matter to me. You're still sexy and sweet.
When they go low, I go high.
No one can compare. Many have tried, but they fall short of getting there. The strength of two men when you're up against the wall, with the world on your shoulder, you tend to stand tall. My sister, my sister, sister. There's something about that girl. I love my sister.
Full of business leaders and surgeons and barristers. I see women who are going to win elections and science competitions and arts awards.
Said she's fine, fine, pretty fine. The girl walks by, she blows my mind. Every time that she walks by, she really blows my mind. Fine, fine, pretty fine. The girl walks by, she blows my mind. Yes, she does.
And we choose excellence.
Peanut butter too. I love you.
How young you are, your age, you can achieve anything that you set your mind to.
I love you. Dark and lovely. I love you. Peanut butter too. I love you. Caramel tone. I love you. Mocha chocolate and red. I love you. I love my sister. I love my sister. Sister. There's something about that girl. I love my sister. Sister girl. Oh, how I love my sister. I love my sister. Sister. There's something about that girl. I love my sister. Sister girl. Said I love my sister. I love my sister. Sister girl. There's something about that girl. I love my sister. Sister girl. I love my sister. I love my sister. Sister. There's something about that girl. I love my sister. Sister. In my background sing. I love my sister. I love my sister girl. I love my sister. I love my sister. In my background sing.
And when they say you're not beautiful,
I love my
you tell them that you are the descendant of royalty. And you are a queen.
I love my sister. I love my sister girl. I love my sister. I love my sister girl.
Wow. Wow. That is awesome. When I saw that video for the first time, I was just taken away. I was just taken away. We come in so many shapes, sizes, and colors. A new day is on the horizon. Not even I can stop me. When they go low, we go high. We choose excellence. When you set your mind to doing what you want to do, you will do it. When you tell them about your beauty, you tell them that you descended from royalty. You are a queen. That video moves me. It moves me. And when we're dealing with all the struggles and challenges that are going on with the inequities in all parts of socialization, education, employment, housing, the inequities that exist, that the Black Lives Matter movement have unearthed. This message is so needed to build people's self-esteem, to make sure that they understand that they are beautiful. And that's why this event is focused on women's, Black women's health matters. And to start the opening ceremony, I have Miss Morgan Williams Bryant and Dr. Diana Callender. So I'm going to introduce Miss Williams Bryant. Before I do that, we have a feature, and what we're doing is Black Excellence in Medicine, Untold Stories. So I'm going to tell you the story of Rebecca Davis Lee Krimpler, the first Black woman doctor in the US. In 1864, a 33-year-old woman named Rebecca Davis Lee Krimpler became the first Black American woman to earn a degree in medicine. Awarded by the New England Female Medical College, a pioneering institution that became Boston University School of Medicine in 1873. Dr. Lee Krimpler would have turned 190 this past February 8th, 2021. We applaud Dr. Lee Krimpler for her being a trailblazer and setting the way for other African-American women to want to be in medicine. Thank you. Now I will introduce our poet for today. And as you can see, they are matching in their pictures when they submitted their pictures independently, and they are matching today with their pink and red. So this is wonderful. You know, it was ordained to be with the way that they are matching, and today is the first day they have met each other. So our poet today is Morgan Williams Bryant. She is a recognized voice in leadership development and empowerment, a dynamic motivational speaker, author, and trailblazer in her field. Morgan's work has transformed the lives of countless individuals and inspired audience of all ages to embrace a champion-level mindset. Without further ado, I'm going to turn it over to Ms. Morgan Williams Bryant.
Good morning. I should say good afternoon. Good afternoon, everyone. I want to thank Dr. Sapp for inviting me to speak with you, and also happy Women's History Month to you. So as women, I noticed we are so darn good at so many things: caring for others, nurturing others, celebrating others. There are also a few things that I noticed that we don't always take time to do, and or we don't do it enough. And that is celebrate ourselves, compliment ourselves, and give ourselves the grace that we deserve. We admire the great women we often see in the spotlight: Michelle Obama, Oprah Winfrey, Ruth Bader Ginsburg, our mothers, our grandmothers, our aunts, our godmothers, cousins, teachers, mentors, and so many more. We stand in awe of their greatness, of their significance, of their journeys. And the truth is, they are great and their journeys are admirable. And it's okay to admire them. But today, it's about you. So pause and say, yes, me. And I want you to put your hand over your heart and say, today is about me, celebrating your amazingness, your journey, and your significance. So there are a few things that I have on my heart to share with you this afternoon. Did you know that most definitely we are celebrities, vibrant and extraordinary queens, and preferred and guaranteed stock of whatever the universe needs? How about an exquisite educator, a solid social worker, the bomb banker, an amazing college admissions counselor, a savvy sports department director, or a majestic stay-at-home mother? We got it covered. From a professional fashion fair to a simply divine eye glare, we've got style, class, a spirit of jazz. We are the walking definitions of pizzazz. Exclusive, unforgettable, and essential. We are all uniquely original. What can I say, my sisters? We are undeniably phenomenal. We are the world's vision of victory, a collage of legacies, tall, short, light, dark, and lovely. We are the mirror images of a true lady with integrity, continuously making waves and soaring to new heights. If people wanted to see a galaxy of stars, they need to look towards us, because every night will be their night. We are dazzling, uplifting, swinging, blossoming, humbly breathtaking. Our intelligence shines bright enough to light up any midnight alleyway. Stunning. We look good even on a bad day. Beautiful sisters, we must take time to get out of our own pity party debt and begin depositing only our greatest assets. Come from behind those fearful towers. Ladies, you are warriors. Tap into and release that talented, brilliant power. Grace the world with an up-close and personal encounter. God only designed us to prosper. What a luxury it would be to walk around carrying you as your greatest accessory. You've got grace, your leadership penetrates, and just the mention of your presence hydrates the driest place. You glow, you flow, you rise like the sun, you glide like a swan, you soar like an eagle, you stand strong and tall as a blessed steeple. Oh, my Gessinger ladies, I must confess, because we are the best of the best, this serves as another great world premiere featuring none other than you, my dears. So ladies, tell anxiety and worry to sit, and sisters, stand, demand, and command, because you got it. Sisters, stand, demand, and command. You certainly got it. Matter of fact, step forth and grace your own royal carpet. Thank you, ladies.
Wow, that was wonderful, wonderful. I'm doing reactions. We're getting stuff in the chat box. Fabulous, amazing. Thank you so much. You got a bunch of claps up on the screen. That was awesome. That was awesome. Everyone could feel that, especially as women, right?
Absolutely.
So I want to thank you. That was fantastic. Thank you so much. So I'm just reading some of the comments I'm seeing in the chat box. If folks want to open up their mics and say stuff, they can do that as well. But that was phenomenal.
Thank you so much. And thank you all for your graciousness. I appreciate it.
Thank you. Well, thank you. You started off our ceremony. If anyone was feeling low self-esteem or feeling down, they are empowered by your words and inspired. So thank you so much. And it's really to set the tone for the rest of the month and what we're going to learn. We're going to be talking about disparities in healthcare, and that is going to be hard. But we have to shine a light on that type of stuff in order to get us to where we need to be, to understand how we could provide services, how we could be intentional and the programmatic initiatives that we offer. So that was very uplifting. And I know that Dr. Callender is coming up next, and she's going to be talking about health disparities in Black women. But we don't want you to be discouraged by that. We want you to find knowledge in that so that we can put it on your radar, make you aware of those type of things, so that when we move forward to provide solutions, when we move forward to figure out how we could step in and be intentional in the wraparound services, resources, tips, and strategies that we use, it's helpful. We need to start somewhere. We need to know where the root of the issues are to move us forward. Okay, so I'm going to go ahead and introduce Dr. Callender. Very, very excited about inviting her back on campus. She's a former associate dean for Geisinger Commonwealth School of Medicine. And we're so excited that she's still engaged in the community because of her love for the students, because of her love for her work that she does. And so, you know, I'm just going to read her bio and then let her step in. I'm not going to take up too much of your time. So after graduating from the University of the West Indies School of Medicine, Dr. Callender completed her hematology residency at UWI and then a clinical oncology fellowship at the National Cancer Institute in Bethesda, Maryland. Dr. Callender has also served as a senior staff fellow at the NCI. Dr. Callender has served as a hematologist and oncologist in Barbados and Dominica, and has been a medical educator for over 25 years. She recently retired from her role as an associate dean at Geisinger Commonwealth School of Medicine in Scranton, Pennsylvania. She has 3 children and 2 grandchildren and lives in Ellicott City, Maryland. Without further ado, I would like to introduce Dr. Diana Callender.
All right, well, hi everyone. It is great to be taking part in this. Thank you, Dr. Sapp, for inviting me. And as Dr. Sapp has said, this is quite a challenging topic that we're going to be talking about. And it is also a huge topic to discuss because there are so many dimensions when we start to talk about health disparities in the Black community and health disparities in Black women. So what I want to do is talk a little bit about what are health disparities, discuss some of the common health disparities seen in Black Americans and Black women, talk a little bit about the social determinants of health and how they may affect the health of Black women, and reflect a bit on how disparities might affect your health or the health of your patients, your families, and your own personal decision making. So I've taken the information from a number of government websites, such as the CDC, and I do this deliberately because not infrequently when Black Americans speak about things like disparities, it's not always taken seriously. So I wanted to pull up some federal resources. There are also some other resources that I'm using, but you'll see a lot of them have to do with government data and databases. Just be mindful that the data varies because sometimes you see different time frames, for example, 2018, 2013 to 17, 2005, 2009. So don't look more for the trends and the fine analytical details. And also you'll see that the studies are sometimes categorized racial groups differently. So you may include Hispanic numbers for Blacks and whites, or may separate them out. You'll also find different terminology depending on when the study was done and who did it. And it doesn't always delineate Black male versus Black female. So you may have Black versus white, male versus female, but sometimes, and I didn't drill down to go to the primary data to do my own analysis. I took what I could get from their websites and the various tools that they offer. And I'd like to say there is a wealth of data available on disparities from minority communities. I must stress that I'm focusing on the Black community today, rather than the Hispanic community, Native American, and the many different communities that are experiencing disparities. And I just wanted to share this. So as many of you know, Healthy People 2020 is one of the programs that have been going on for decades, and where the government sets different objectives and looks to see how we can improve the health of communities over time. And we just ended the Healthy People 2020 program and have now started actually the Healthy People 2030. But I found that some of the information from Healthy People 2020 was very helpful. And they define a health disparity as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. So health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on racial or ethnic group, religion, socioeconomic status, gender, age, mental health, disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. And you can see that Black women fall into, without other things such as disability, fall into multiple groups that are discriminated against. It is really important to recognize the impact that social determinants have on the health outcomes of specific populations, and we'll be drilling down on that a little more later as we go through the presentation. So African Americans are more likely to die at early ages from all causes than white Americans. And you can see from this that across the life cycle, and African Americans or Black are the red bars, and white Americans are the blue bars. You can see there are a greater number of deaths per 100,000 people for African Americans across the life cycle. For females born in 2015, the life expectancy is 84.3 years for Hispanic females, 81.1 for non-Hispanic white females, and the lowest 78.1 years for non-Hispanic African American or Black females. I want to talk a little bit about COVID, more to get this is one example. This is something that has been in the news a lot in terms of COVID revealing or highlighting, I should say, because the information has always been there, the disparities in our society and the individuals that are at greatest risk for contracting COVID. So when you look at it by ethnicity, you see that Black communities are 13% of those who are positive for COVID, Hispanic or Latino, 11.9 or 12%, and other races take about 30%. The lowest are the Asian and white communities. And some of the factors that come into play here are the neighborhoods in which these individuals live and the physical environment, housing and how, is it congregate housing, is it multiple generations in housing and so on, and the occupation, are they frontline workers, essential workers, grocery store clerks, bus drivers, those types of things that put you at greater risk. One example of this is looking at Atlanta, which is a high Black population. You see, of those individuals who are hospitalized, 79, almost 80% were Black, while 13% were white. For those with COVID who were not hospitalized, 45% were Black, and about 30% were white. Similarly, when you look at deaths, you'll see that in looking at cities and states, looking at a selection of cities and states, there were 34% of the deaths were among non-Hispanic Black individuals. And this group takes up about 12.8% of the total US population. So you see that disparity there in the number of deaths. And in a nationwide analysis, counties with a higher population percentages of non-Hispanic Black people experience higher COVID confirmed cases and death rates than counties with higher percentages of non-Hispanic whites. And you'll see as we go through, the majority of the comparisons are between Black and white population. Another snapshot I'd like us to look at is cardiovascular disease. So in 2018, 1 in 5 American women died of heart disease. Deaths from heart disease are more prevalent among African American, Native American, and Hispanic than among white women. And this is not entirely surprising because some of the factors that increase the risk of developing heart disease, including high blood pressure, diabetes, and obesity, are also higher in these groups. Taking a look at cancer. And since we were focusing a little bit on women, let's talk about breast cancer. So Black women have higher death rates from breast cancer than other women. And in 2009, a report, Vital Signs from the CDC, gave some of the following figures: that 40,000 people die of breast cancer each year in the US. Black women are 40% more likely to die of breast cancer than white women. And almost 2,000 fewer Black women would die of breast cancer if death rates were the same as white women. Since over the last 10 years, the trajectories of the incidence of breast cancer have changed a little bit in that in 2017, Black women were getting breast cancer at about the same incidence as white women. Despite that, you still saw the difference in the mortality rate. And the thing about this is that the disparities occur at each phase of the breast cancer care trajectory, from diagnosis to treatment. So, similar rates of mammography use among Black and white women have been described, and this is usually national self-reported data. And this actually is something that we see in the data from the Department of Health in Pennsylvania. However, some studies verifying self-report have suggested that maybe, in fact, the actual mammography use might be lower among Black women. But even if you were to have the same rate, Black women are more likely to have longer intervals between getting the screening mammogram, between each screening mammogram. So for example, and this is not exact data, if white women got them every 2 years, perhaps Black women got them every 3 years. So there's a longer interval and a greater chance for cancer to develop between screenings. Timeliness and adequacy of follow-up also varies by socioeconomic, community, and health system characteristics. And so if you're dependent on Medicaid, for example, then as against commercial insurance, your ability to have the follow-up on the adequacy may not be as good. Even among women with similar insurance status, however, Black women have longer intervals to diagnosis after an abnormal mammogram than white women. So even after a lesion is detected, the follow-up, the notification of the Black women and the follow-up for treatment is longer. For example, 20% of Black women had diagnostic intervals of over 60 days compared to 12% of white women. And again, this comes from CDC data and morbidity and mortality monthly, weekly. Breast cancer prognosis also varies by subtype. And breast cancer, as many of you know, is subtyped by the presence of receptors, estrogen, progesterone, or human epidermal growth factor. There are more treatment options available, and a more favorable prognosis is present for tumors tumors that have these receptors than for those that are negative for all three receptors. And compared to white women, Black women more frequently have tumor subtypes with poor prognosis, especially triple negative breast cancer. And the reasons for this are still being evaluated. Some studies suggest that things like obesity and so on are related to the more aggressive cancers, and whether it is genetics or whether there are these other factors that cause this is still being researched. So advances in breast cancer treatment are estimated to be responsible for about a quarter of the recent decline in breast cancer deaths. Several studies have reported that Black women do not receive the same quality of treatment for breast cancer as white women. And one modeling study showed that up to 19% of the mortality differences between Black and white women could be eliminated if the same treatment was provided for both populations. And again, just going back to the timeliness, fewer Black women, about 70%, start treatment within 30 days compared to white women, 82%. So time from diagnosis to starting treatment is another predictor of outcomes. Just a quick mention of cervical cancer, again, as we're focusing on women. The incidence of cervical cancer is highest in Hispanic women, 8.9 per 100,000 versus 8.3 per 100,000 for Black women, and lowest in white women. But like many cancers, the mortality is highest in Black women compared to both Hispanic and white women. So one of the statistics and the data, this is actually one of the most challenging presentations I've made because it gets a little bit overwhelming. But some of the data that stands out, even among some of the other data on disparities, and again, I like to say that there are tremendous disparities in outcomes in terms of Native American, Hispanics, and so on. But again, we're focusing on African Americans today. But one of the statistics, the sets of statistics that I find most distressing is maternal mortality. And so in 2018, maternal mortality statistics showed the wide racial and ethnic gaps. So we found that for 100,000 live births, about 37 Black women would die, as against about 15 white women and 12 Hispanic women. Now, none of these are acceptable, but again, it does show the gap. What is interesting about this data is that the US has the highest maternal mortality. And so looking at a snapshot in 2018 or comparing them whenever their latest data was available, the US has the highest maternal mortality of 10 developed countries. And it's thought that partly because the United States does not make use of midwives and additional healthcare providers in the same way of many other countries. And one particular thought is that because we have such a large share of the maternal deaths occurring after birth, the United States is the only country that does not guarantee access to home visits, provider home visits, or paid parental leave in the postpartum period. And thought that these are some of the factors that lead to this. But other factors come into play. So looking at infant mortality, again, looking at for every 1,000 live births, you'll see that for Blacks, there are 11 babies die. For whites, 4.7. So a Black baby is more than twice as likely to die in that early period than a white baby. Similarly, the features that lead to this have to do with characteristics of the mother. So we find that far fewer Black women received prenatal care in the first trimester than white women, and many more than twice as many Black mothers received late or no prenatal care. So another snapshot we can look at is mental health. So this is a very complex issue, as are all of the issues we're discussing. But Black people are less likely to have or to be diagnosed with mental illness, which is, I think, really interesting. But despite that, they are likely to have more prolonged negative outcomes because of the quality of care. And one of the things I found very interesting as I was researching this topic was that last month, actually on Martin Luther King Day, the American Psychiatric Association, the Board of Trustees, issued an apology for a history of racism in the APA and psychiatry, and for enabling discriminatory and prejudicial actions within the APA and racist practices in psychiatric treatment of Black, Indigenous, and people of color. This statement of apology was accompanied by a document outlining specific practices and policies, including failures to speak out and protest racist practices that have damaged Black and Indigenous people and their family, dating back to the APA's founding. An example, I think probably the most extreme example of this, was the so-called drapetomania, which was a mental illness conjectured by an American physician, Samuel Cartwright, in 1851. And he hypothesized that enslaved Africans fleeing captivity were mentally ill. So wanting to flee being a slave, having your children taken away and sold, being beaten, was a sign of mental illness. In the statement, the APA's trustees acknowledged that early psychiatric practices laid the groundwork for the inequities in clinical treatment that have historically limited access to quality psychiatric care for Blacks and other people of color. This includes things such as the overdiagnosis of schizophrenia in Black men, and the fact that many of the incarcerated Black men have psychiatric illness and that their only treatment is received while incarcerated. But some of the details of this include the fact that obviously I would think poverty affects mental health status, and African Americans living below the poverty level versus those over twice the poverty level are twice as likely to report psychological distress. And I think that's obvious to anyone, and I think that would occur to any group. One interesting fact is that the overall suicide rate for African Americans is 60% lower than that of the white population. Despite that figure though, one worrying statistic is that in 2017, suicide was the second leading cause of death for African Americans aged 15 to 24. And I have a family friend whose teenage son committed suicide. The death rate for suicide for African American men was 4 times greater than that for African American women. And again, there are many societal reasons for this. But another worrying statistic is that African American or Black females in grades 9 to 12 were more than 70% likely to attempt suicide versus white females of the same age. So I alluded to some of the disparities in treatment earlier, and just drill down on these a little more. So only 1 in 3 Black adults who need mental health care actually get it. And according to the American Psychiatric Association, Black adults are less likely to receive guideline consistent care, less frequently included in research, are more likely to use emergency rooms or primary care rather than mental health specialists. The barriers to care include socioeconomic disparities, which go hand in hand with insurance and access and all the rest of it, and stigma. There are negative attitudes and beliefs to people with mental health throughout the US in all communities, but this can be particularly strong with the Black community. And one study showed that 63% of Black people believe that a mental health condition is a sign of personal weakness. And many people seek support from their faith community rather than seeking a medical diagnosis. I think it's really important here, as with all of these, to think about just how diverse the Black community is, that in addition to the native-born African Americans with their own set of challenges, there are immigrants from Africa, the Caribbean, with different languages and so on. So the African American community is a very diverse community. And so there are going to be different cultural beliefs affecting all of the health issues that we've spoken about. And along those lines, I just wanted to share a little experience that I had, maybe take a little break from some of that pretty dire information, about something I found about my own attitude to my healthcare. So I've always prided myself on being a very rational person, and because of my education and training, the way I take decisions. And 3 or 4 weeks ago, I noticed a very, very dark spot on the sole of my foot. Now with age, I've started to get some more darkly pigmented lesions on the sole of my feet, but this one was particularly dark and black. And having been an hematologist, I naturally thought of it being a melanoma. And so was worried that I could have had some form of cancer. So being particularly privileged, I had access to good care, and I was able to see a dermatologist pretty quickly. And she was white, but I had absolutely no problems with the quality of care. The interaction was excellent. She looked at it through a magnifying glass, excuse me, and said that all the characteristics make it suggest that it looked benign. And we could either observe it or we could biopsy it. And I had a very strong visceral reaction. I wanted that thing off of the sole of my foot and into a bottle. And I thought about it, and I realized after that despite I knew, and this was information or a recommendation I would probably have given to a patient to observe it, I had this very strong visceral reaction. I'm sorry, excuse me. And this went back to the fact that I went to medical school in Jamaica. So, and residency and my young adult life formative years were in Jamaica. And at that time, Bob Marley with his reggae was a very prominent force, a social force in terms of looking at the Black African Caribbean experience and speaking out against it. And in 1981, Bob Marley died of melanoma. He had a lesion on his foot, which was malignant and had spread. And I realized after the fact that this feeling of dread I had about this lesion on my foot was linked in some way to have that profound effect the death of Bob Marley, who I never met, had on me. And so it was biopsied and came back as expected, benign. And so that made me think about how that was not necessarily a wrong decision, but it was also not necessarily a rational decision I made to have a biopsy when everything pointed to that being a benign lesion. And I just wanted you all to pause a moment and think. So I've just shared a lot of negative data about disparities, and we're going to go on to talk a little bit about social determinants of health and so on. But I'd like you to think a little bit about what are some of the things that influence your decisions about for healthcare and the choices that you or your family and friends make. And this has nothing to do with race. This is, are your decisions always fact-based? What are some of the things that influence your decisions? And what are some of the factors that you think may have influenced the women or the individuals that make up those numbers that I shared with you in terms of adverse health outcomes? And if you could just either raise your hand, or if you could put something in the chat, then Dr. Sapp would address it.
I will call on folks if you want to raise your hand, or if you want to put it in the chat. I will read it out and Dr. Calendar will address it. What do you think are the factors that lead to these outcomes discussed? What are some of the factors? Does anyone have anything? What factors have affected your personal choices for healthcare or those of your friends, family, or patients? So some factors that have affected some folks is taking care of other things and people first, past experiences in a clinical setting. I hate going to the doctor and having everything blamed on my weight. Those are some factors that folks are sharing. Okay, thank you for having the courage to put that in there and share that. Very powerful, right? What other factors have led to some outcomes or not going to the doctor? Any other ones? So those are the ones that we have to date, Dr. Calendar.
Okay, all right. I think it is particularly important to pay attention to the comment about worrying about what the physician will say about their weight, because this is something that others have said, that sometimes the physician thinks that they're being, or they are really out to be helpful in terms of saying about diet and exercise and so on, but that can actually, how it is done and what is said can actually be a deterrent to further health care. All right, so
and you know, I would even add echo what that individual said, but I would even add that given unrealistic timeframes to lose the weight as well, right? Because my person gave me a month, and I pretty much told them that's not going to happen, and I'm going to take the full year, and then we can get back and we can talk about this more. But if you don't have people who can advocate or people who feel comfortable, and I just looked at my physician and I was like, you're not even being realistic. You're going to give me a month to lose 10 pounds. I'm going to tell you that's not going to work, and we're going to look at something different. But I will do my part to lose the weight, but it's not going to happen in a month. Are you kidding me? You want me to change my entire diet? I'm going to try to gradually introduce some things. And we talked about that. And so it became more realistic. And she gave me a list and we talked about it. I'm like, in a month, 10 pounds with my age, that is not going to work. So I think that that's part of it as well. So I definitely echo what that person put in the box about talking about your weight or things. Two other people entered some statements as well. Fear of religious beliefs not being met. That's one. And fear of getting an answer you don't want to hear. That is so powerful. You're like, I don't want to know. I don't want to know, I can definitely understand that one as well. So those are some other ones that were entered, Dr. Calendar. Oh,
and,
wait.
and the fear of hearing that you have cancer is a particularly strong factor. In my experience, that keeps people away from even getting screenings. And I think the point is that it's important to realize just how much a role emotion, and sometimes the emotions that we are not even aware of, have in playing in terms of care and access and response to what the healthcare provider has. All right, so we'll go on because we have another.
I have one more. I'm sorry.
No. First.
Didn't go to the doctor when I was a kid. My dad died in a hospital and my mom wouldn't take my sister and I after that. So even now, when I know I should go, I don't have the habit, and I have the old fear. So even talking about trauma, right? How trauma presents itself.
Right. And these are all factors with all people, right? All socioeconomic, racial backgrounds, and they're colored obviously according to the belief systems, according to the culture, according to the issues and the personal experiences that you have been raised with. And I think this habit of regular health care is a really important aspect to it. All right, I want to go on now, keeping those types of things in the back of our mind. I also want to go on and talk about some other concrete factors that affect healthcare access and the ability for everyone to be the healthiest they can and live their best life, so to speak. And we all talk here about the social determinants of health. We talk to medical students about this. We talk to colleagues about this. I just want to drill down a little bit on some of these and how this affects the Black population and Black women. So this has a lot on it. This slide has a lot on it, but it's important to remember that the social determinants of health, such as education, economics, and so on, affect a wide range of health, functioning, and quality of life outcomes. So simple things like access to parks and safe sidewalks for walking affects physical activity in adults. And physical activity is one of the great ways in decreasing many negative health outcomes, from cancer to heart disease, diabetes, and so on. Education is associated with a longer life expectancy, improved health and quality of life, and health promoting behaviors, what we were just talking about, having regular physical activity, not smoking, having routine checkups and having the recommended screenings like mammograms and colonoscopies and stuff. The other impacts, such as that things like discrimination and stigma or unfair treatment, even in the workplace, have a profound on health. Discrimination, a perception of discrimination can increase blood pressure, increase heart rate and stress, as well as undermine self-esteem and self-efficacy. The places where people live and eat affect their diet, which affects health. So more than 23 million people in the US live in food deserts or neighborhoods that lack access to stores where affordable, healthy food is available. So there's a lot of healthy food in the supermarket, but it is very expensive usually. So the CDC identifies some of the things, the social determinants that go with worsening health outcomes or health disparities. Unemployment, which again here, the red bars are African American, the blue bars are white, is higher in African Americans across the lifespan, their work life. Living in poverty, African Americans are more likely to live in poverty, and they are less likely to own a home. And home ownership is one of the major ways in which Americans build wealth, and wealth not only for themselves, but to pass on to children, or wealth that can be tapped into to pay for education. Educational attainment is important. And this has been well described that poor people do not have access, by and large, to quality education. 86% of non-Hispanic Blacks 25 years and older had earned at least a high school diploma, compared to nearly 93% of non-Hispanic whites. 21% of non-Hispanic Blacks had a bachelor degree, compared to nearly 36% of whites. A trend that has been seen over the decades is that more Black women and Black men earn at least a bachelor's degree. And this comes with other societal and issues around relationships and marriage for Black women. And only 8% of non-Hispanic Blacks have a graduate or advanced professional degree versus nearly 14% of whites. This translates into income. So the average non-Hispanic Black median household income was about $40,000, compared to just over $65,000 for white households. And about 23% of non-Hispanic Blacks living in poverty, compared to almost 10% of whites. It's important to note that the unemployment rate for Blacks was twice that of non-Hispanic whites. And remember how closely income and health insurance status are linked in the US. Moreover, when we're thinking about Black women, about 30% of Black households are headed by women. Now there are many reasons behind this, going back to the destruction of the Black families in slavery, the legacy of that, but more recently to the mass incarceration of Black males, which has had a very disruptive impact on Black life. Let's drilling down a little bit more on women, however. In 2016, women had a higher poverty rate than men. So women on the whole, all women, more women live in poverty than men. And these rates are highest for working women. And the poverty rate for women aged 18 to 64 was 13.4%, men in the same age was about 10%. Although women on the whole live in more women live in poverty than men, the rate for African American women is 21%, and the rate for the nation as a whole is 12%. So in addition, when you look at this and you see the results of systemic racism, even when you drill down even further and look at the disparity or the discrepancy between Black women and white women, you see that white women make more money relative to Black women. This is for the same income or for the same job. So going with education and with jobs and with income and with access to care and access to information, you come other behaviors that adversely affect outcomes. So in terms of not being able to see a physician because of costs, again, the red bars are Black people, the white are the blue bars are whites. More Blacks could not see a physician because of cost than whites. Smoking in the younger age groups was much the same between Black and whites, but higher in the age group 50 to 64. And as you know, smoking has many adverse outcomes from lung cancer through increasing rates of other cancers. Inactivity, which is again linked with many adverse health outcomes, is again linked to income and education and is higher in Blacks across the lifespan, as is obesity, which is linked to exercise and to poor diet. So we have seen the effects of systemic racism on income, education, access to care, resulting in these worse health outcomes. But one of the things that we're seeing more and more, and we're seeing this as I was doing some research looking at from the American Psychiatric Association, the American Bar Association, to a number of other bodies, as well as the community as a whole, are starting to talk more about social justice and about health equity. Achieving health equity requires valuing everyone equally, and it requires focus on ongoing efforts to address the avoidable inequities, the historical and contemporary injustices, and the elimination of health and healthcare disparities. So this is, I think many are hopeful with some of the changes that we're seeing and some of the awareness and some of the work that many are doing towards achieving social justice and health equity. I think having Vice President Kamala Harris is one hopeful sign for others and young people like Amanda Gorman. And I think we need to all work towards achieving this goal. I'll stop here and ask for questions. I'm not sure how many questions I can answer, but more I'd like to hear your comments and your thoughts about some of the information that I shared. Dr. Sapp?
Wonderful. I'm looking in the chat box. I don't see anything as of yet. So if anyone has any questions, if you would like to drop that in the chat or raise your hand, I can call on you. We can do that as well. So any questions? One of the things, Faith has a question. Faith, can you open your mic and share your question, please.
Dr. Sapp, I'm sorry, I don't have a question. My iPad is twitching on me.
Okay, no problem, no problem. Dr. Townsend has a question. Dr. Townsend, you can open your mic.
Yes. Hi, Diana, again. This is nice to see you twice in a week. Fabulous. So I have a comment and a question. So sometimes hearing about all this can feel overwhelming. And I was recently cleaning out my office in Danville to move to a different office and kind of seeing the decades and decades of reports of, and when we first started using the word health disparities, et cetera. And yet, there are places and there are institutions and there are cities who may begin to make dents on some of this. And one really treasured piece of advice that I've heard given by our colleague Denise Rogers, who's at UMDNJ, but was actually the chair of our accreditation review panel for the Middle States, was that you really have to start looking in your own backyard. And so I think one thing for those of us being here, I recognize we could have people from outside of this region, but we're in Northeast and North Central PA, and really think about what kind of data we might already have available relating to health disparities in practices, disparities in outcomes. We know that Geisinger, as one example, has begun to pay quite a bit of attention to social determinants of health, has community health assistance in many of the practices and more integrated care in the practices, but there's so far to go. So something that might be tangible and possible, and then thinking even of the BOLD group that's gotten together, which is people across professions and disciplines thinking about these issues, that might be a tangible place to start and identifying, are there a number of things, what do we know about our maternity care and our outcomes? What do we know about, some of these common things? And so I was just wondering, Diana, if in your travels and, so many people from healthcare institutions and medical schools across the world, if you've seen examples of communities or institutions who've taken on something and can demonstrate some successes in this arena at the local level. That's a hard question to answer on the spot, but you might have some examples, even from your own experience.
I think there have been some advances made in the United States. The death rate in African Americans has been, the gap in the death rate between white and Black Americans has been narrowing over the last 20 years. And some of these disparities have been narrowing. I think the problem we have is a societal problem, because I think the fundamentals that we have to address are the minimum wage. I think poverty, we have to look at the educational system. So recently there was a comment in DC about needing to address the number of students there who are not reading at grade level. And so in communities where there are these clear disparities, the only way is to direct funding, because I think one of the great equalizers that we see is education. Education is one of the great equalizers, and obviously access. So in terms of what I've seen internationally are like the European health system. Who's that visitor?
That's crazy. Just a new household member, Diana.
Conversation, a typical Zoom moment. But I think the thing is also the access to care that is not linked to income, the healthcare that's not linked to income and education. That's why I kept talking about poverty and health insurance and income, because I think those are the strategies globally that have worked best to help address disparities. And the other things are some of our beliefs and behaviors. I mean, the fact that the American Psychiatric Association felt like they had to make that comment, that statement about their own policies and their guidelines and their so on, and they're not acknowledging the stressors that the Black community lives on because of discrimination and the fact that they either dismissed it in interactions with patients, that speaks volumes for some of the institutional changes that we need to make. But I think the first thing is to accept, and the reason why you saw almost every slide, I had a link to an agency where that information came from, is to accept that the problem is real.
Thank you.
Thank you. Dr. Callender, I really appreciate you stating that. It's so interesting because Glynis Johns is the president and CEO of the Black Scranton Project, and she gave a talk at the University of Scranton, and she's also a historian, right? And that's her whole goal, is to highlight Black people. And I use the term Black because it encompasses everyone. I try not to use African American because it has the American at the end of it, which is a nationality. And so I try to use the term Black to encompass the Black, the African, the Black American, the Afro-Latinx, the Afro-Caribbean. So I try to use that term to be all encompassing. But my point is that she was given a talk for Black History Month for their Black Student Union, and she uncovered a lot of things that the University of Scranton did with their Black faculty. They used to auction off their Black faculty for, it hurts to say this, you know, but they auction off their Black faculty to be a slave for the day or a slave for a week. And she unearthed this and she brought it to light during the talk. And the provost of the University of Scranton actually issued an apology to the Black community. And so that apology was so powerful for the Black Student Union. No, they were not there during that time, but now that they found out the history of what the institution used to do, they felt compelled to issue an apology. And at first they took it off of the website, so they had the different links, and Glynis Johns asked them to put it back up. That's history. We're not trying to erase history. We want to highlight what has happened in history so that we don't repeat it again, right? And it's so important. So I really appreciate your point of understanding that, no, we were not there, but understanding to give that apology to try to heal some of the hurt, the trauma that people have been through, right? So thank you for that. Question. In your talk, you talked about grades 9 through 12, Black females are more likely to commit suicide. Did they say why that was the case? What was going on? Those are such formative years. And, you know, with that video that I showed at the beginning about beauty and Black beauty and understanding what that is, what institutions were they at? You know, I always have concerns.
I did not drill down into that detail. I was thinking of my granddaughter, and they used to have so many things to do, like the image of beauty and beautiful. So I've been in a pod with my daughter and my son-in-law and grandkids. And so I help with combing, because she's working from home and they're at home, I help with combing my granddaughter's hair. And I make sure each time I wash her hair and I'm blackening her, I say, you have such a beautiful head of hair. I make sure I keep, in terms of self-image and self-esteem, you know, my granddaughter, oh, you're so beautiful and intelligent, my grandson, which they are.
Yes, they are. I've seen it.
But those, and I think one of the things that will help, hopefully, are, and the reason I showed the pictures of Amanda Gorman and Kamala Harris is seeing these pictures of successful Black, powerful women is, I think, important, again, in that self-esteem and building that. But unfortunately, we are also seeing what I'm sure the epidemiologists have told me I'm not using this word correctly, what seems to be an epidemic of suicides among the young, you know. And those reasons go from Facebook and seeing what seems to be a perfect life in everyone else to the stresses from bullying and at school and increased expectations. But no, I did not drill down to see what the issues were.
Thank you. Any other questions? You can open your mic and speak. I think we have a smaller group that we can do that, or you can put it in the chat box. Any other questions?
So I see from David Manning asking if there's research that finds that the same racial, ethnic, and health disparities in other developed countries, are they more prevalent in the US? If so, do we know why? I did not look into that. I just know from my general knowledge in looking at the news and so on, you see, my understanding is that you see similar racial ethnic disparities in England, and you see similar in France. I think those might be mitigated somewhat because of the nature of their health systems, where they, you know, in England, you have a broader national health service with more access. But I did not drill down. The closest I came to that was the maternal mortality information I shared about the maternal mortality in the United States being so much higher than it is in other countries. And they're linking that to the type of health system and the fact that the mothers and the infants have access to providers and midwives and so on in their homes and much broader access than we do.
Thank you.
I would be surprised though if there were not racial and ethnic disparities in every country, because unfortunately, I think it is part of human nature to see people from other groups of other, not to value them as much, and for them to live in greater poverty and not have as much access. So I would be surprised, but I suspect it may not be as great because of depending on the nature of the health system.
Okay, wonderful. We have one more question. Dr. Jeffries, I see that your mic is open, and after that, we're going to turn it over to Faith so she can close us out. Dr. Jeffries?
Thanks, Dr. Sapp. And it's part of the reason why I wanted to ask a question is just to say hi to Dr. Callender and say I miss you, I miss your contributions, and I miss talking to you. So nice to see you. So here's a question I have. I have been approached more than once by a medical student who is dismayed by the awful state of medical care in this country, particularly the health disparities that you're talking about. And the question often comes back and they say, well, what's the medical school doing about this to remedy the health disparities in the country? And you know, it comes from a wonderful place of optimism and true concern on the part of the medical students, but also a great deal of naivete with respect to how medical schools in the country influence the health system. So my answer is usually, well, the way my plan to fix the health system is to put you in it. But what do we tell medical students? How can this medical school influence the reform of our system to better address health disparities and to make this a more equitable health system?
Okay.
Well, it's an easy question for the end.
Yeah, I know. It's good to see you, Bill.
Nice to see you.
I think it's multi-tiered. I think it starts from our epidemiology courses and our cultural competence training. I think the addressing the physician behaviors, which is part of this, the physician biases and the behaviors wherein that Black mammograms as much are for pap smears or the different screenings or counseled or advised to have them as much as white women. So I think those are one of the things that some studies have shown that physicians have biases against people of lower socioeconomic group or minority groups. So this whole cultural competence, this whole implicit bias training, I think is one way to start a conversation. I think their mindfulness in terms of educating their patients. So I think putting them into the health system is one answer. I think the schools sponsoring community outreach programs for education in terms of the vaccine, in terms of the safety of the vaccine, helping with access to the vaccine in communities of color, disadvantaged communities in general. I think that in terms of the student groups, so we have so many active groups that can help with that. So both at the university itself level and the student group level to help them with the education, because this lack of education is one of the fundamentals, one of the causes of the disparities. And I think that Geisinger has the foundations, hopefully have the education of the residents and the physicians themselves within this about the disparities and about the underlying foundational causes. Because I think people from majority communities tend to dismiss these and said, well, I pulled myself up by my bootstraps, they can too. So I think that widening awareness of how deep these disparities go and the causes. So I think at those multiple levels, the provider awareness, the student individual awareness, and then the community outreach, I think those are things that would be powerful tools in the communities that Geisinger serves. Yeah.
Wonderful. Thank you so much for that, Dr. Callender. And thank you so much for coming in to speak to us. That was a great question, Dr. Jeffries. Really appreciate that. So thank you. Thanks, Miss William Bryant. She is actually raffling off one of her books for us today. So if you are interested in getting one of Miss Williams Bryant's book, A Champion's Prayer Journal, 25-day faith journey, please put that next to your name in the raffle. If you already put your name down to be raffled off for a mug, go back in and write book next to it if you're interested in the book. So thank you so much, both of you. You've been great. Now I'm going to turn it over to Faith to close us out. Thank you both so much. We're getting off to a great start. Faith?
Thank you, everybody, for joining us at the opening ceremony today. We started off on the right foot for Women's History Month. Tomorrow, the Geisinger Women Lead, ERG, will be doing their vision boards. That's tomorrow from 10 to 11. And then we're going to continue with our Black Women's Health Matters series on Thursday with Dr. Alexia Norwood. And then Friday, March 5th, we'll be doing our Black Women's Health Matters series with Dr. Kwanzaa Humphrey from Key Bank. And we'll have many more events throughout the month, but that's just for the week. So if you could register for the events, I believe on the next slide, Dr. Sapp has the QR code. You can scan that so that you can register for the events. And thank you, Dr. Callender and Ms. Morgan William Blight for joining us today. Take care, everybody.
Bye-bye.
Bye.
Wonderful. That was just wonderful. Perfect timing. We have 1 minute left. This is awesome. Thank you all for coming. Thank you. And I'll announce those winners at the next event. I typically send them an email. So the winner, we have 5 mugs and 1 book. That is wonderful. Thank you all so much for coming. We have some comments in the chat saying thank you. This was wonderful. Wonderful. Bye-bye. Have a
Bye.
wonderful. Hope to see you on Thursday and Friday of this week.
Okay.
Looking forward to seeing you tomorrow, Thursday, and Friday of this week. Oh, okay.